今天的案例呢是一个关于脱垂的案例，然后呢，这个案例呢是主人公的名字呢叫做刘大姐，刘大姐呢是一个3个宝宝的妈妈，然后她最近一次的这个生产呢是在10周之前，她这个老三生了下来，然后呢分娩史上面来说呢就是老大呢是就是比较这个分娩的过程比较痛苦，差不多4个小时左右。然后老二呢是剖腹产，然后老三呢相对于来说前面2个还比较顺利。然后刘大姐啊，她主要就抱怨说她在就是产后恢复的时候进行就是她这个各种锻炼的时候呢，她会有漏尿的情况。然后同时呢，她说她这个阴道里面呢会感觉有东西。然后在照顾宝宝，然后长时间就是喂奶啊，或者是久坐的情况下呢，她这个骨盆带呢也会有疼痛。尤其是在1个礼拜之前吧，她去做这个 Pap smear，Pap smear 中文我是真不知道是什么，就是这个查 HPV 病菌的那个，就是女性同胞呢，差不多每2年都要做一次，所以呢，她这个1个礼拜之前去做这个 Pap smear，然后她说那一次就是跟她以往的这个情况都不一样，然后她觉得那一次特别的，就最近这一次特别的痛苦，然后特别疼，然后就是差不多生了宝宝10周左右吧，然后她跟她的这个爱人呢还没有就是有任何这个性生活。然后他自己呢也没有这种自慰的习惯。就还想你们还需要知道一些什么？我再想想啊。平常呢锻炼呢，他会比较喜欢用这个登山机和椭圆机，也会照着一些 app 或者说是像这种 Keep 的这样的一些 app 呢做一些力量上面的训练。所以他其实就是主要呢就是想就是因为他还没有恢复性生活，但是通过 Pap smear 这个情况呢，他可能会有这个性交痛的情况，然后他也呢就是而且脱垂的这个现象也很明显，加上漏尿，所以呢就是主要我们要帮他解决的这几个问题呢就是这些，然后这个案例呢就是这样，然后在接下来的时间呢，我会跟朱莉老师围绕着刘大姐的这个案例呢，跟大家就是好好的聊一下，这种情况，其实在我们这个女性同胞中是出现的比较普遍的。然后呢，应该通过怎么样的一个比较科学的方法来，就是慢慢的解决这些个就是小问题。好，那我们现在就接朱莉老师。
So the first and most important thing to look at is how she breathes into her pelvic floor and her diaphragm, and how it's connected. So her breath pattern, when she leans over to pick up her purse, when she picks up the baby and puts it on the plinth, I'm watching. What is she doing? Is she holding her breath? Is she releasing her breath when she picks things up? And when she breathes, is it like short, shallow chest breaths, or is she, able to breathe deep into the diaphragm? First thing I do is watch her breath and see if she's expanding here or here, and if she can, relax and take healthy breaths, because that's how she's going to start to engage the pelvic floor. I'm going to assume she's coming to me saying she's bulging. I'm going to assume she's got a weak pelvic floor already.
Mm-hmm.
So, of course, I'm going to assess her pelvic floor, but first I'm going to look at her breath. Okay. And then the second thing I'm going to look at is her length tension relationships of her muscles. So, quickly assess her pelvis and her SI joint and see if she has a little scoliosis, see if she has, because she's complaining of pain in sitting. So what are her sit bones doing? Is she sitting on one more than another? Is her sacrum lined up right? So real quick, look at length of her psoas, her adductors, strength, in the pelvic girdle, in the proximal hip stabilizers, the internal rotators, and see if there's any differences right to left. And we did find that her left side was a little bit weaker.
Right.
And then the last thing I would do would be an internal exam and look at her pelvic floor strength to see if she could contract, and if one side was thinner or thicker than the other, and if there was any pain, because she said she had pain when she had a pap smear.
Right. So based on those 3 assessments, what do we find?
So her primary problem was that she wasn't breathing into her lower abdominal wall. She couldn't engage when I asked her to contract her pelvic floor and I looked at the trans abdominal ultrasound, she just braced. That's all she did. All you could see was that her rectus abdominis were contracting solid every time she would try to lift her pelvic floor because
So
she
you
wasn't
was-
getting breath
So
down
she
into the
wasn't
pelvic floor.
engaged in her TA at all. Okay.
No, I couldn't feel any TA. Well, if I felt TA, I felt everything else, coming in, like
Okay.
holding, bracing. She was like bracing. And it was more like a reflex almost, not like a natural breath pattern.
Mm-hmm.
So that was one thing. The other thing was that she had the weakness in the left hip. And she said that, and her sacrum had soreness on the left side in the vagina when I pushed on the left side of the sacrum. And then the internal exam looked, unfortunately, on the left side, she had what was called a disappearing labia, so it was smaller on one side than the other.
Mm-hmm.
It's actually like, if you look at it here, it's my model. It was like shrunk on the left side.
Yeah.
But she didn't have any sensory problems or pain or anything, and there
Okay.
wasn't any feeling different on the right or left. And then internally on the left side, it was thinner, and the vaginal vault was not. We wanted to be, like 10 centimeters. It was like 6 centimeters, so it wasn't quite long enough. I couldn't get into the vaginal vault, and it was painful to have inserted my finger. So
Right. So in terms of
like 1 out of 5.
1 out of 5. All right. So in terms of what's in your brain at this point, like what was your clinical decision making? Because it seems like everything was very concordant on the left.
Yeah. It seemed like she had a crush injury, but probably not with this pregnancy. It was a very traumatic birth. They had to take it out with a vacuum. She had a lot of, she had an episiotomy. She had a lot of pushing for a long time.
Mm-hmm.
So I think when that happened, that compartment on the left had a crush injury either to the vein, the artery, or the nerve. And so that's why the nutrition to that area kind of shriveled up a little bit. And then the muscle being, thinner, I think that was also from the previous birth. So this birth didn't, I think, cause anything except that now she had, this weakness, and she was not able to reconnect.
Right.
I think that she probably had disconnected from her pelvic floor for a long time ago, and now she couldn't like bring everything back in.
So did you guys have the conversation of why she came to see you this time versus previous?
Well, this time she said it was different because she felt something down there. She felt something in her vagina, and she was leaking.
Okay.
So she would cough and leak urine, and she'd never had that before.
Mm-hmm.
And so I think it's kind of like pelvic floor injuries kind of go like that. You get like a little injury, and then it builds. And then the next time you get an injury, maybe you have more problems storing urine, or maybe you have more problems with prolapse. It's like initial injury of maybe the muscle not being as strong. It was okay. She made do. But then, now with the prolapse, she had more problems.
Right. Yeah. So I think that's also
she was nursing.
Uh-huh.
So there's inherently some ligamentous laxity.
Right.
So that's going to stay, everything's going to stay a little bit loose. And so she's not going to feel as put together as she continues to nurse, which is fine. It's normal, but it does make people a little bit freaked out.
Mm. All right. So what were your 3 interventions for her?
So the first thing I taught her to do was to engage the diaphragm and the pelvic floor together. Mm-hmm. So I had her lie flat so that she could, her path, her airway was completely open, and her legs were flat, not bent. And I just had her breathe, have her place her hands on her lower abdominal wall, breathe into her hands, let her lower abdominal wall rise, and then as the breath comes out, have her engage the pelvic floor. And if she was still and quiet, kept everything quiet, and just focused with her hands, she could feel her TA come on. Mm-hmm. She'd say, oh, okay, that's what I'm supposed to do. And so that was like the first thing I had her do. Then we tried to carry that over to, okay, now do that when you're sitting up, do that when you're standing, do that when you pick up your foot, you know, try to engage it in different functional positions. Because like lying down, she's not going to have any problem. She's not going to leak urine.
Right.
She's not going to have any prolapse because she's lying flat. But she has to learn to connect the two. So the next thing was to do functional positions with her and have her engage it when she could. And that was a little bit harder. Then the third thing I had her do was I had her try these functional dilators, which are little dilators that you put inside the underwear, and they go up in different sizes. The functional dilators are a little different than the ones they lay down with. Functional dilators they put in while they're standing up.
Yeah.
And they keep them in while they're standing up. So if the underwear is tight enough, it'll hold them in. Mm-hmm. And the idea there was for her to be able to feel the right position of keeping when she contracts. Because if she braces, then the dilator gets pushed out.
Okay, yeah.
And so if she contracted properly, the dilator would stay in. But she couldn't keep it in for more than 5 or 10 minutes because there's a lot of pressure. And she was really shocked that the pap smear hurt. And she was like, I don't know why the pap smear would hurt. And I said, well, with a prolapse, you have a more narrow and smaller vaginal vault. So anytime you introduce something into the vaginal vault, all the bricks to get a sample, you know, it's going to hurt if you have a prolapse. So we need to work on, you know, getting that opening better so it doesn't hurt.
Right.
So, yeah, I mean.
Did you do any manual work on her?
Yeah. So I also did some myofascial release in the ilioinguinal canal to help get nutrition to the pudendal nerve, the dorsal branch. And then I also did some myofascial release at the crease here, right? About 1/3 between the belly button and the ASIS, right in there to try to free up the nerve as well. Because it was a little bit on the left side, it was more uncomfortable than on the right. Well, I taught her to contract before she did anything that would increase her intra-abdominal pressure. So we call it the knack, where you squeeze and then cough, squeeze and then blow your nose, squeeze and open, pick up a sack of groceries, squeeze before you open a jar of mayonnaise. It's like trying to get a new breath pattern so that she's not breath holding. So talked about breath patterns while she's holding and how to prevent that. And also like, is she drinking enough water? Talked about bowel and bladder habits. And is she straining to go to the bathroom? Wanted to make sure that that's a big part of patient education. Anybody that's prone to have prolapse, you want to make sure they're not a strainer when they're going to the bathroom and that their stools are soft and formed, and you're making sure they have the right nutrition so that they're not having, to go 3 days without going to the bathroom and then straining, because that'll stretch out the muscles and increase the prolapse as well.
For people who might have been, who's been experiencing similar things, or for PTs who are dealing with patients who have multiple things going on, what should we be aware of as PT, and what should patient be aware of as, how to deal with these problems? That's a two-part question. So for the PTs and for the patients.
From a PT standpoint, I want to get her to feel success. I want her to walk away feeling like she understands like the the how-to of it all. Once she put her hands on her body and then she could feel it, then she was understanding. So the first job of the PT, I think, is to make sure that you're relaying the message. And then for the patient, they need to, be able to measure it. They need to be able to understand, like if I have her keep a journal, a bladder journal,
Mm-hmm.
and I say, okay, keep track of how much water you drink and how many times you go to the bathroom. And then in a week she comes back and she's like, oh, I don't have to go every 60 minutes. I can go 2 hours without going to the bathroom. Then I'm like, okay, do you see how you're getting measurable success? Because you're holding more urine in your bladder, and that means your muscles are getting stronger. So trying to get buy-in from her so that she can continue to work. Because I think there is kind of a feeling of it's never going to get better,
Right.
It's just useless.
So what would her prognosis looking like? Like when can she return to all these other aerobic activities?
So I would say she could probably return to like level 2 would be in about 4 to 6 weeks. She should have some functional improvement, and her bladder should be emptying less frequently, because you can increase your bladder capacity like 15 minutes a week. So if she's going every half hour or every hour, in 4 weeks she should be going every 2 hours.
Mm-hmm.
And at that point you want to add resistance. So as she's engaging the pelvic floor, then you want to start having her like blowing up a balloon, giving some resistance, intra-abdominal pressure, and seeing if she can maintain the TA without bulging, and working in different positions, working on the Swiss ball. Maybe bouncing on the Swiss ball would be okay. It's a little bit of perturbation, but she's got to be able to maintain her TA while she's doing it. Does that make sense?
Yeah. So we're looking at like a 4 month that she should be.
I think 3 months. I think realistically 3 months she should be able to run down the street and run after her 3-year-old. I think in 3 months. It's usually like 4 to 6 weeks for functional changes, and then 12 weeks for muscle hypertrophy, to get that muscle thicker and able to support the organ better.
So I hope this video would help both, the Chinese community and probably even some of our American colleagues or PT students to understand better about pelvic floor, and if they're interested in getting to women's health specialists, I think this is something that could help all of us. Yeah. All right. So thank you, Julie, for coming on.
Yeah.
And I will send you the video, or I will post it, and then you will see it